Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Courtney Smith. Today's episode features an expert discussion on management strategies for NASH in patients with HIV by Dr. Mark Sulkowski from the Johns Hopkins Bayview Medical Center in Maryland. This episode is part of a larger educational program titled, Don't Forget About the Liver, NASH in Patients with HIV. For more information on Dr. Sulkowski, along with CME-certified Medical Minute modules with downloadable slide sets and clinical thought commentaries from experts, please visit the show notes for this episode. Now let's get started and hear what Dr. Sulkowski has to say on this important topic.
When I started my infectious diseases training, our patients with HIV suffered devastating and often fatal illnesses related to acquired immunodeficiency. In the early days of highly active antiretroviral therapy, our patients frequently had abnormal liver enzyme levels due to many threats to the liver: drug-induced liver injury due to medications used to treat HIV and its complications, chronic hepatitis B and hepatitis C, and alcohol-related liver injury. Non-alcoholic fatty liver disease, or NAFLD, and non-alcoholic steatohepatitis, or NASH, were rarely on the differential diagnosis in the late 1990s and 2000s. As I think about our patients with HIV today, my first thought is, wow, we have made remarkable progress with safe, tolerable, non-liver toxic antiretroviral therapy, which can also treat hepatitis B, and with Nobel Prize winning advances in hepatitis C treatment. Yet, our patients frequently still have abnormal ALT and AST levels. Why? With control of HIV, our patients have gained weight, like many Americans, possibly due to antiretroviral therapy, and developed metabolic diseases such as cardiovascular disease. Although we still need to consider potential contributions of reported and unreported alcohol consumption when we evaluate our patients with elevated liver enzymes, in the absence of alcohol, NAFLD or NASH is near the top of my differential diagnosis, particularly in persons with elevated body mass index, diabetes, hyperlipidemia, and other metabolic diseases. I educate and counsel my patients on healthy eating and physical activity and how these conditions can affect the liver. I also order tests to detect the presence of steatosis or liver fat, and if detected, to quantify the amount of fat. I typically start with liver ultrasound and, when possible, transient liver elastography to quantify liver stiffness, a correlate of liver fibrosis, and steatosis using the controlled attenuation parameter, or CAP score. I also like to determine the FIB4 in all my patients. It's based on readily available tests, AST, ALT, and platelet count, and easy to calculate using online calculators. And of importance, the score predicts mortality in people with HIV monoinfection. I also consider liver biopsy for some patients, especially those for whom the cause of liver abnormality is uncertain. Why do I work these patients up? Well, if unrecognized, our patients with undiagnosed NASH are at risk for liver complications, including cirrhosis, liver failure, hepatocellular carcinoma, and even death. Because liver disease can progress over time, I also talk with my patients about the need to continue to monitor the liver with blood tests and ultrasounds. If we recognize NASH in our patients, we can focus on evidence-based interventions for healthy eating, better glucose control, and, where available, disease-directed therapies. Although weight loss is challenging, multiple studies demonstrate clinically significant improvements in NASH and clinical outcomes in patients who lose approximately 5 to 10% of their body weight. Both the American Association for the Study of Liver Diseases and the European AIDS Conference Society guidelines recommend lifestyle modifications as the foundation of NASH treatments in patients with HIV. Therefore, I refer patients to expert healthcare professionals who have established a multidisciplinary approach to managing patients with an obesity-related medical condition. Further, based on results of published trials, professional society guidelines discuss the potential role for pioglitazone in people with biopsy-proven NASH and vitamin E, 800 milligrams daily, and persons without diabetes. In a small study of 61 people with HIV and non-alcoholic fatty liver disease, the growth hormone releasing analog, tesamorelin, taken for 12 months, reduced liver fat compared to placebo. And the European guidelines mention this option with the caveat that larger studies are needed. In patients with obesity, medications for weight loss and bariatric surgery are also important considerations. If my patient has both type 2 diabetes and non-alcoholic fatty liver disease, I talk with the endocrinologist or primary care provider about the possibility of treatment with a glucagon-like peptide-1 receptor agonist like semaglutide, which has evidence for diabetes management, weight loss, and some emerging evidence in NASH. My patients also need to know about clinical research underway to identify novel NASH treatments. But I stress we need to take action today to improve their liver and overall health. An abnormal ALT is never normal, and our patients with abnormal liver enzymes need our attention and consideration of non-alcoholic steatohepatitis. What are your thoughts? How do you treat NASH in your patients with HIV?
Thank you very much, Dr. Sulkowski, and thank you to the listeners for joining us. As a reminder, to view the full program and to join the discussion, please click on the link in the show notes. As always, thank you for listening.